start. Okay. Well, good afternoon. It's 12 o'clock on a Tuesday afternoon, so it must be time for grand rounds. So I'm Dr. Brian Reed. I'm the chair of the Department of Clinical Sciences here, and really want to send a big thank you to the City of Houston Health Department for being here today. We originally had this scheduled on January the 16th, but we had the winter emergency and weren't able to have it on that day. So here is Dr. Jeannette Lopez Belen and Mayela Cabrer de Bravo. They're both physicians as well as epidemiologists over at the City of Houston Health Department. And Dr. Kenneth Stanley is also with us today, this afternoon. So this is something that we wanted to actually present last fall and winter, and unfortunately things are still an epidemic standpoint, with syphilis. So, we did want to talk about this outbreak. So today's topic is stopping the spread of syphilis, why the clinical and public health coordinated intervention is the clue. And today's objectives are to explain the role of public health in the prevention, intervention, and control of diseases, identify Houston demographics and local social determinants leading to the syphilis outbreak, describe the diagnosis of syphilis and provide appropriate treatment to patients, and lastly, discuss the Houston Health Department strategies in response to the rise in syphilis and congenital syphilis cases. So thank you.
Hello, everyone. Are you able to hear me? I'm so happy to be here today. My name is Dr. Jeannette Lopez Belen, and I'm going to be actually talking to you a little bit of our perspectives in the health department regardless this outbreak. And also, we're going to talk a little bit more why the clinical setting and also why the public health part it's going to be important when we're managing, for example, syphilis cases. Now, I want you to see these two images that we have right here. It's very hard to swallow when we have babies that keep being born with an infection that is actually 100% treatable and also preventable. So that's why it's very important to go along with the clinical setting and also the public health part so we can just, stop the spread of the disease. But first, I'm very dynamic. I'm a very dynamic person. I do have here Mentimeter. So if you join to Menti, MENTI.com and use that code 78276793 and just answer this question. So we're going to hear speak a little bit about what is public health, why it's important, and why do you think is very key or clue to stop, for example, infectious diseases. So let's take a minute to do this. Science in prevention, that's basically key. Community prevention, intervention. What else comes to your mind when we just say public health, why it's important, community. So overall, public health, it's a science, as it's well stated here, but this is the science to protect the community. So it's going to be protecting us as part of the community. It's going to be protecting basically everyone from our family members, friends, etc. And actually with the purpose to, get rid of infections and keep actually the people protected. So here we have one of those Mentimeters from the past, a very big audience we had. And not only, what I want to emphasize from this slide is that not only public health is going to be able to protect us against infectious diseases, but also from anything that becomes, or it could be a threat to everybody's health. For example, the health department, we have been involved working with, for example, the freezings, that's one of them, or also hurricane season. So anything that it could pose a threat to anybody's health, public health is gonna be there to keep everybody safe and healthy. But now public health, actually, it's going to be led by 10 essential services. And these essential services, what they do is they provide a framework. And this framework at the end, it's basically going towards equity. Why is that? So why do you think that we need, for example, certain framework over there just to keep everybody healthy? So at the end, there's a lot of social determinant factors that are going to be involving and actually posing a threat to somebody's health. So that's why it's very important to have a framework to keep going with the public health service. But now I'm going to explain to you a little bit where do we belong to? Because actually here in Texas, we have 8 public health areas. And actually Houston, we belong to the public health region 6-5, okay? On each one of those regions, we have local health departments, and these local health departments, what they do is that every time that we have something notified to us, we're gonna be able to investigate those cases. And as an epidemiologist, that's part of my work. It's basically investigating cases, making sure, for example, that these patients that were reported to us, they were adequately treated, they were correctly staged, and also we do partner services in the nature of the disease that we work. But now, in terms to know a little bit about our population, and also the services that we provide, probably as providers or maybe public health practitioners, we need to know and understand how is our community. So Houston, it's a very diverse population. We have about 2.4 million people living only in Houston area. And this is just excluding Harris County. So we even have more that we cover. But Houston is very heterogeneous. When I'm saying that, we're very diverse. We have a lot of people coming from other countries. We have we're located near a border with Mexico, for example, and we do receive a lot of people here that need services to keep everybody, to keep them healthy and all that. But something that it just got to my attention is that we have about 15.8% of families that are living under the poverty level. And this is very concerning. And the reason it's because, if you don't have access to healthcare, if you don't have access to insurance, if you cannot go maybe to your doctor to get that mold check or maybe that rash that you just had. So here we're missing opportunities. That's why public health, it's going to be important. But how do we receive these cases? So in Texas, actually, there's a law and an administrative code that it requires providers, laboratory settings to notify and report notifiable conditions. And here I have an example of the form that we use to report for STDs or sexually transmitted diseases. The only thing is that we don't only have, sexually transmitted diseases that are needing to be reported. Also, we do need other conditions to be reported as well. But this, for example, is a very good one that we use for that. So syphilis is the one that we're going to be focusing today. And the reason is because we are seeing an outbreak. We're seeing an increase in cases, and we need to help our community, because if the community is safe, everybody then is going to be actually on that safer zone. But what happens after we receive these reports? So basically, this is going into our surveillance system. That surveillance system, it's called TCs. And then once we receive that, we have investigators that are going to be the surveillance investigators. What they do is that they do a provider follow-up. I'm not sure if you're familiar in your practice, or maybe you have heard this before, if you have worked in a facility, in a clinical facility. Most of the time, these SI workers, they call just to make sure to get the details. And when I'm saying the details, they're going to be actually calling in regards in behalf of the infection. They're going to be asking for symptoms. They're going to be asking for the stage that probably the provider gave to the patient, and maybe the treatment. And this is going to become important because with the flow of the investigation, once we have this part done, actually the DIS, which is the disease infection specialist, it's going to be actually taking over the case. And the DIS has a very key and important role. So here today, we brought 4 of our DIS. They're just right there. They're actually identified with their blue shirts. And if you have any questions at the end, they're going to be more than happy to answer any of them. So the purpose of the DIS, mostly it's doing partner services. Why is that? So if we think a little bit about the nature of the disease, so we're talking about syphilis. We already know it's a sexually transmitted infection, but let's say that you as a provider, you treat the patient, you're able to give that treatment to the patient was able to take adequate treatment, etc. But then there's a gap. What about the partner? So these patients, they can get reinfected. So that's why the DIS, it takes a big role in the game at this point, because they do those partner services. And not only that, also those patients that are reported to us that they don't have any treatment, or maybe they're not staged, they're gonna go, to take care about this. So they go and look for these patients, they go and stage them, and according to the CDC guidelines, and also they do link them to services, not only for the partners, but also for treatment. And most of the time, actually, I'm gonna say that all the time, this treatment is gonna be actually covered by the clinics that we have available. So once this job is done, then it's just reported, and then we just can continue, working with other cases. But now I have here a clinical case, and I want you to focus at this point on the role of public health, okay? So we have a Mentimeter coming up. So the question is just down there, what is the role of public health? So I'm just gonna read this clinical case, okay? So this is a 25-year-old female. She's 8 weeks pregnant. She went to her first prenatal visit, and she reported she had a painless lesion in the perineal region and rash on palms and feet that started a month ago. She also reported hair loss with unspecified time evolution. At her first prenatal visit, labs were performed and results came as follows. She had a rapid plasma reagent, which is the RPR of 1 to 256, and the TPPA was reactive. She was diagnosed with secondary syphilis, and 1 dose of 2.4 million units of benzathine penicillin G was given. Patient also referred her sexual partner also had a lesion on his penis, and 3 months earlier. And he was treated with 1 dose of 2.4 million units of benzathine penicillin G at the health department clinic 2 weeks later. At 26 weeks of pregnancy, she had a new RPR screening, and her titer was a 1 to 8, which actually it means it dropped. That treatment worked. But then at 30 weeks, her titer was 1 to 1. And then at delivery, at 40 weeks, her RPR was a 1 to 8. Baby was born with an RPR of 1 to 2, and the cephalospinal fluid protein was 73 milligrams per deciliter. So at this point, I'm not going to ask you what's the clinical part, but what's the role of public health in these clinical case? So here we have another Mentimeter. I'm just going to wait for your responses. Same code. So how do you think public health is going to actually protect this patient, protect the baby, and also the partner? Case investigation, document prevalence, limit the spread, primary intervention, investigation. But I think the most important part here, besides all that you just have mentioned, like surveillance investigation and all that, it's partner services. Because if we don't cover the partners, then we're going to see reinfection. And that's actually indeed what it happened to this patient. So if you remember, her titer was dropping. She was a 1 to 256. Then she was a 1 to 8. And then with the nature evolution of the titer, that titer kept dropping to 1 to 1. But what happened when she delivered that baby? Her titer went up to a 1 to 8. So that's basically concerning to us, because it's telling us that that patient got a reinfection, even that the partner was treated, even that the partner was elicited. So what I want you to see from this case is that even that we do our part, also we need from everyone to start educating the patients and telling like, hey, we need your partners to get treated. We need your partners to get tested. This is not something that we're going to judge you. This is another disease like any other else, and we're just here to help, okay? So now I'm gonna talk a little bit about how syphilis is actually affecting our area. And this is actually one of my favorite parts, because I'm a data person, and this is telling us if something is working or maybe is not. So here, for example, we have that annual case count from 2017 to 2022. So I want you to see that on 2017, we roughly had reported roughly 3,000 cases. But then over the time, we started like seeing an increase. And then on 2022, we actually reported a little bit more than 5,000 cases. So what do you think happened here? Like, why we sort of like seeing this increment in cases. We're gonna give you the answers in the follow slides, but actually the pandemic aftermath was one of them. People were not going to get tested. There was no screening. And then actually it just went a little bit out of control, okay? Now, here, this is actually the breakdown according to the sex, okay? So typically we have seen over the time that sexually transmitted infections, they affect mostly male population. But even that here in Houston, we can see that male population has continued to grow. Also, we have noticed that the female population also is growing. And from the previous slides, when we were talking about the Houston demographics and also how the Houston population is, one of the things that we have there is that the female to male ratio is actually 50 and 50%, like 1-to-1. And that's actually concerning because actually we're seeing an infection that it wasn't very common, it was not very common spread in the past. Now it's actually spreading a little bit more. Here we have about background and ethnicity. And we see here such disparities. For example, we can see that Black African American populations, they're actually getting infected 4 times faster in comparison to those of Hispanic population and to those of non-Hispanic, non-Black white populations. So why do you think this is happening? Here is where we have to think about those social determinant factors of health, okay? So for example, if somebody doesn't have access to care or maybe cultural beliefs, for example, I'm Hispanic and my father, he never wants to go to the doctor. So how do I, how do I fight that back? So basically that's why education, it's gonna be key. And that's why education, it's gonna be like that power source to actually help this, to stop the spread of the disease and see these disparities that we've been seeing. Here, this is about age group, okay? So all the age groups, they're being affected. We have been seeing an increase in all of them, but for example, in the male population, the highest rate was in the age group from 25 to 34 years old. And in females, the highest rate was from 20 to 24 years old. So that's telling us like, hey, female populations are getting infected at a younger age, but why? Now, this is the part that actually it's concerning me more because here we have the case count about congenital syphilis. As we know, syphilis is a sexually transmitted infection, but it can potentially be transmitted vertically to, from mom to the baby through the placenta. So here we can see that in 2017, in the Houston area, we only have reported 43 cases, which we should have none, right? We should have 0. That should be our goal. But then see in 2018, so it actually duplicated and then it increased by around 50% more. And then since then, on 2022, which is the last data analysis that we actually had here documented, it just kept like, the same number. But why? I mean, why babies? They are seen being born with a disease that it's 100% treatable and preventable. So the challenge here, it's about the treatment adequacy. The challenge here, it's about the staging of the disease. And also the challenge here, it's about the partner. So we're seeing a lot of reinfections. And that's why at the end, it's pretty key to educate everyone. This is a hotspot map that we have from our data department about those areas that has actually the higher density of cases. Okay, so if we can see right there, the Texas Medical Center area, that downtown area, it has like more concentration of those cases in comparison to other zip codes, but then see that west area, okay? So when we think about here, like, hey, why these zip codes are getting more infected, why we're seeing a lot of spread of the disease, so we have to think about those social determinant factors of health. For example, if you're like living under the poverty level, if you don't have like, for example, you cannot afford rent, or maybe you cannot afford your food, so why you're going to be thinking about your health, right? So here in these areas, in these zip codes, we can see populations that basically they're like living on house. For example, in the Texas Medical Center area, we see a lot of homeless population. In the west area of Houston, for example, there we have Bissonnette Street. And when it comes to work, so what about Bissonnette? So this is an area where we see a lot of sex workers, for example. But then actually, these hotspot, it's very important to us because it helps us understand where do we need to allocate those resources to actually help this community and then stop the spread. But now I'm going to talk to you about syphilis. Like if we, for example, we already talked about the role of public health. We already talked about the data and get to know a little bit more about how syphilis is affecting our health. But also we need to know to stage, how to actually adequately treat a person in terms to, properly treat and then therefore stop the spread. So syphilis, first off, it's caused by a bacteria. This is Treponema pallidum. It's on a spirochete. And then it has been called the great imitator. Why it has been called the great imitator? The reason is because the symptoms that we're going to encounter in syphilis, they're not pretty characteristic or just for that disease. We're going to see, for example, the rash. We can see rashes in other affections. For example, the HIV rash that we also see, it could resemble that of syphilis. We also have lesions that it could happen by any other diseases. But for example, in syphilis, we have very special keys that are going to help us and guide us to understand it's the infection or not. I know now I have pretty graphic images, but the reason why I brought them, it's because I want you to see how is that lesion, how it's going to look. For example, syphilis is going to be actually broke down into stages, okay? Early stages and late stages, okay? Now, the early stages versus late stages, here the key, it's going to be the symptoms, the time of duration, and then at the end, Dr. Mayela is going to talk to you about the treatment for each one of them, okay? So primary syphilis, it's characterized by a chancre, okay? That chancre is just no more than a lesion, but that lesion, it has something very important that we're not going to see in any other lesions for those, for example, of herpes, caused by herpes, or maybe chancre. The chancre of syphilis is not painful, so it's painless, okay? So that's telling us something. So males, for this reason, actually, they're gonna like get to know like, hey, I have something going on. And something very important about this chancre that is that it lasts for about 2 weeks and then it just fades away. So it just goes away. Now in females, okay? In females, if the chancre, it's localized inside of the vaginal cavity, and because it doesn't hurt, it's gonna go unseen, okay? But this stage right here, it's very, very infectious, okay? What it's telling us is that spirochete is just like basically there in that exposure site. And actually, we're not only going to see the chancre in the genitalia, any part of the body that it's exposed to a chancre is going to have the possibility to develop one, for example, in the oral cavity. Now, secondary syphilis. Secondary syphilis, here we're going to see a lot of different symptoms, okay? Now, when we are talking about secondary, what it means is that spirochete bacteria has made its way into the bloodstream. So here we see hematogenous dissemination. Okay, that's why we're going to see all these non-specific symptoms, such the generalized body rash, the alopecia, and those that I'm going to mention in a moment. For example, here we have the most common one that we're going to see in secondary syphilis, which is the generalized body rash. This generalized body rash, it can go from head to toe, and most of the time, we're going to see that it lasts for at least 2 weeks, and then it's non-itchy most of the time, and then it goes away by itself. So if you have a patient that it just comes to your facility or your clinic, and then it say like, hey, I just want to get tested for syphilis, it's very important that we do a very thorough physical examination and physical medical history. Why? Because these symptoms, they just fade, they just go away, and then they can just guide us into the diagnosis. Here I have an image that we're distinguishing between fair or light skin complexions and dark skin complexions. Why? Because that rash is gonna look totally different, okay? For example, when we're investigating our cases, most of the time when we talk to the patients, we ask like, hey, do you remember having like a rash in your body, or maybe like this palmoplantar rash, how it was, what was the duration? And most of the time the patients say, oh, no, I didn't have anything. I don't remember having anything. First, because this rash, it goes away. Second, because sometimes it doesn't even look like a rash according to your skin complexion. And most of the time, for example, darker complexions, they just refer as this rash as dark spots. Okay, so when we ask, we're like, hey, do you remember having like a dark spot in your hands or maybe on your skin? And then the patient, oh yes, I remember. I looked like a Dalmatian like 6 months ago. So yeah, and then you're like, okay, how long did it last? How long did you have that rash? Oh, it lasts like for about 2 to 3 weeks, and then it just went away. So I thought it was nothing. That's why syphilis is called a great indicator, and that's why it's very important to conduct a very thorough physical examination and medical history to the patients. Now, here we have other symptoms related to secondary syphilis. For example, we have mucus patches, and also we have condylomedullata, okay? In the case of the mucus patches, we're going to see that they're going to be appearing actually in moist areas, for example, areas that are lined with mucosal tissues like the oral cavity or maybe the genitalia. So they're not gonna hurt at all, and then they can just like, fade away, same as we saw with the and also with the generalized body rash. In the case of the condylomedullata, these one can resemble other affections. For example, those warts that are produced, for example, by human papilloma virus, I mean, it could be a differential diagnosis, right? But at this point, when we see a patient with this type of lesions, actually, this is very infectious because even that bacteria has made its way into the bloodstream, it's still right there, in the skin, okay? And then basically it can, get people more infected, right? Now, other symptom, which is not that common, but we can still see this one, it's the alopecia. But this alopecia, actually, it follows a pattern. So it's called the moth-eating alopecia. So if you see right there, we're going to see like sudden hair loss on different areas of the scalp, but also it can resemble other affections like alopecia areata, for example, which is an autoimmune disease that also we're going to see sudden onset of hair loss in patches, right? So once again, the great imitator, that's why it's very important to take a look on these symptoms. And then if you're seeing something like that, just go ahead and test that patient for syphilis, regardless of the exposure history or something like that, okay? We have other types of symptoms, like for example, lymphadenopathy. Also, we're gonna see other systemic symptoms like malaise, also fever. And the reason it's because the immune system is just there trying to, fight back an infection in the body. But these symptoms are not actually as specific to syphilis, but they can actually still occur. And then if it's not actually treated, then it could spread to the liver, it could spread to the lungs, to the GI system, producing, or maybe the heart producing an infection called gommas. And then if it just go untreated, then also it can invade also the nervous system, cause syphilis. And lastly, I have here, for example, the latent stage, okay? And I put it like this because I wanted to reinforce a little bit about how we're going to actually make sure something it's early latent versus late latent. And here, the clue, the key, it's going to be evolution of time, okay? So if somebody, for example, it's going to be staged as late latent syphilis, first, let me tell you that this is going to be important because this is going to help us address the treatment that that patient needs. Because Mayela is just going to explain to you, but for example, early versus late stages, the treatment is going to be a little bit different, okay? But now in late latent syphilis, this is a patient that it's totally asymptomatic, but it's reactive, okay? We have tests that are telling us, yes, this is syphilis. But here at this point, we don't know when did it start, okay? We don't know that evolution time or that infection duration time for the patient, okay? Or maybe this is a patient that it tells you like, hey, I had like this lesion in my private area 3 years ago. So at this point, it's falling under late latent, right? But now about early latent stage, here basically what we're gonna have include, it's the time evolution. This is an infection that actually it has been happening within a year, okay? So for example, this is a patient that maybe it came to your office, it had a wellness maybe 3 months ago, and the RPR was not reactive, with a TPPI not reactive. But then now it's coming back because probably was exposed or for whatever reason, and now he's positive. So you have evidence to support that that patient falls under early latent stage, okay? Also, this is a patient that maybe we can see a fourfold increase on the titer. For example, you tested the patient like 1 or 3 months ago, it was a 1-to-1, but then the patient, for whatever reason, you didn't get treated, but then now you're just retesting the patient, and now that titer went up from 1-to-1 to 1-to-64, okay? So that's telling you actually, hey, there's an active infection, so that's falling under that category. And also, this is a patient that probably it's linked or exposed to somebody who's early as well. And if you're able to support and document that, also you can guide yourself and say, okay, so the treatment that I'm gonna give to you, it's this one, for example, 1 bicycline shot, or maybe the 14 days for doxycycline, and then you're gonna be cured, okay? But it's very important to make the distinction between the 2 stages falling under latent symptoms. Okay, so now, if you don't have any questions about my part, I'm gonna go ahead with Dr. Mayela Cabrer, and she's gonna talk to you about the treatment and different screenings and all that. Thank you so much.
Thank you, Jeannette. Well, syphilis has been a challenge for in our career or our field, in the medical field, because we don't have a specific direct test available as a routine. So we have DAR fields, we have PCR, but not everybody has access to do that. The problem is we diagnose syphilis using indirect tests that based on antibody production. And what I mean is depend for another factor is not coming right now, but we have 2 of them that would have bring to get a specific diagnosis. One of them is a group called no troponemic test, in which we find a RPR, that is a rapid reagent test. And it is very sensible, but it's not specific because it's based on an inflammatory reaction, again, a phospholipid that we find on the membrane. So every single cell has this phospholipid and can be affected by several reasons. We can say, for example, autoimmune diseases, we can say pregnancy status. So it is very sensible. On another side, we have the troponemic test. There are antibody, again, the bacteria, they are considering a specific one. And we have different methodologies to find this or to measure this. So we have fluorescence, for example, the FDA, we have enzymatic methods as a CIS. Also, we have particle agglutination that is considered the gold standard. So right now, we encourage you, even you use the original conventional algorithm or the inverse algorithm, we need both to ensure this is a new infection or it is a really syphilis infection. So, and that is that slide, okay? So now we are seeing, one of the reasons we are here is because we are seeing a lot of false positive when providers use FDA as a confirmatory one. So now we encourage you don't use that. And also we created, this is a kind of algorithm to make easy sometimes get that diagnosis and bring some 3 different scenarios in which we combine the non-troponemic test, the RPR test with the troponemic one. So thinking about the first one that is on the left side, when you have a positive RPR, reactive RPR, and a positive TPPA. What it means, the patient has been in contact, but it doesn't mean this is a new infection. So how we can ensure the patient need treatment or not? Okay. We, on that case, obviously, as Jeannette mentioned, we make a complete physical exams, we make a complete medical history checking for previous diagnosis. But if you got and see, for example, a lower RPR title, don't assume this that means the patient is serophas. It means not all that lower title means the patient is non-infected. So we need to compare. We need to ensure if the patient got previous diagnosis, the patient get adequately treated at that time. Because the natural evolution for any antibody is get down, even you are getting or not getting adequate treatment. So if you get a patient with positive RPR, we can assist you we have, spread to you a card tag that has a hotline number, because we can check for you on our system and see if the patient got previous diagnosis, what is the value for the previous RPR, or if the patient got adequate treated on the past, okay? The second scenario is when we have a positive RPR and a negative TPPA. It means the patient, because the TPPA is a specific one, it means this is a biological valve positive. It is a patient that is not infected, so we don't need to do anything here. And the last one is when we have a negative or non-reactive RPR and a positive TPPA. And that case can be several scenarios. We encourage you at that point, go waiting 2 weeks and retest it again and getting a new RPR. If the new RPR is positive, it means this patient was in incubation time, and we go and treat it as an early stages. If the second RPR still negative, probably the patient has serophas, has an old infection. Go and see if the patient has documented treatment. And if the patient is in childbearing capacity, this is our point today, and we don't ensure the patient got adequate treated on the past, go and treat it as a late latent. The point here is antibody also has time sensitivity. And the production for them, we have normally a serological window. So if we can ensure exactly the time evolution for this patient, we say go and treat it as a late. And lastly, we have a group of diseases, family for spirochete, but it's not sexually transmitted diseases called treponematosis that can maybe cause cross reaction. The point is, we don't have mechanism to diagnose directly these cases, and then I'm gonna go and say, probably is a patient coming from another country, South America or Central America, go and treat it as well as a late. And this is a slide just to show you the time sensitive production for antibodies. After exposure, 2 weeks after that, the component, the IgM component for the treponema test start production. And after 4 weeks for the exposure, start the IgG component for the treponemic test and the RPR component, both IgG and IgM. That means sometimes, depending on the kind of mechanism or the time that you tested, we can say negative test. That doesn't mean. On that point, we have to get in about the history, the exposure, okay, the risk factor that maybe the patient has to, smell something happen and go and retest it again. And this is a slide that resumes what kind of treatment is necessary by CDC guideline. If you diagnose, that is why it's very important diagnosis stages as well. If you get diagnosis for early, primary, secondary, or early latent stages, just 1 dose for benzathine penicillin is necessary, though for 2.4 million unit intramuscular. But if the patient is a late latent, we need at least 3 doses. 1 week interval. At that point, I have to say, it doesn't, 1 week, some people, interpret 1 week different. Say 6 days is okay, 10 days is okay, every 15 days is okay. No, by CDC guideline, 1 week means between 7 and 9 days. No before 7, no more than 9 days. So now if the patient is not pregnant, but has documented truly penicillin allergy, the alternative treatment is provide doxycycline 100 milligrams 2 times per day for 14 days on early stages, primary, secondary, and early latent, or for 28 days for late latent stages. What happened with the patient is pregnant, so we need to send to a hospital level for desensitization. And what happened with congenital? Well, syphilis can be transmitted any stages. We know it's faster and frequently on early stages, primary and secondary, but also happen on the late stages and can happen on any trimester for the pregnancy. And can affect the fetus on several ways, maybe producing, preterm born, stillborn, fetal demise, so hydrocephalus, and also maybe the newborn can be affecting several organs and organ system. That is why it's very important checking, for example, hepatic function can produce hepatitis, osteochondritis, radiolucent on the metaphysis from the long bones, a Huntington disease, snowfall, so a very big diverse symptoms and signals. And that is a photo that brings to you rashes, sputum the Huntington disease that we are seeing more frequently. And what happened if any of the mechanisms to prevent syphilis during pregnancy has been failed? So we have 4 different kind of scenarios. The first one is the baby that is highly probably a syphilis case or confirmed syphilis case. Is the baby that has symptoms? Is the baby the mother doesn't have documented adequate treated? And it is the baby maybe titles are higher or for increase from mother. This baby need complete workup. This baby need complete 10 days treatment. Penicillin crystal. The second scenario, is the baby that maybe has probably case, is the baby is asymptomatic, the mother has no documented treatment, and probably the titles are equal or lower than the mother. But that baby is considered probably and also has to complete 10 days for Bicillin on the hospital. The next scenario is the baby that is asymptomatic. The mother titles are equal or less than 4-fold decrease for the baby titles and have document treatment. On that baby, just 1 dose for penicillin is recommended. And the last one is the less likely congenital, is the baby that is asymptomatic, the mother titles, the baby titles are lower than the mother, and the mother has documented adequate treated. And by Texas law, we have to screen in pregnant women 3 times during the pregnancy. The first time at the first visit, the second time has to be on the 3rd trimester, but 3rd trimester means between 28 and 32 weeks, no before 28, no more than 32. Why is the reason? And we have seen a lot of screening at that time because we need to ensure if the mother is reinfected, the baby gets treatment at least 1 month before delivery. And finally, mother has to be tested at delivery. Even it is a law, even it is required by CDC guidelines, we're still seeing pregnant women that has not been screening as well. Some people screening at 26 weeks, some people screening at the 35 weeks. And this is an interactive case just to check at that point how much we are learning so far, okay? It is a 34 years old woman, 20 weeks pregnant, screening for syphilis in her first prenatal care visit and has a positive Treponema pallidum specific enzyme like immunoensayme, that EA. The laboratory performed a reflective rapid plasma regime RPR that is reactive 1 to 16. Tests for HIV, Neisseria, and chlamydia are negative. She has no medical problem, take no medication, and does not use illicit drugs. She has been sexually active with the same male partner for the last 3 years. She has no prior history for any sexually transmitted infection and has never been tested or treated for syphilis. She is asymptomatic and the physical examination is normal. Patient was given 3 doses, 2.4 million units of benzathine penicillin in interval for 7 days. At the 35 week of pregnancy, she was screened again and her new RPR title is 1 to 256. So my first question for you is, what is the diagnosis at the 35 weeks? Yes, she is a reinfection. And the next question is, was the patient screening for syphilis during prenatal care accordingly? What do you think? How many know? Yes. She was screening at 35 instead of the 28 to 32 weeks to get a new diagnosis. The knowledge failed here probably who reinfected her? Who was in care for the partner? Was the partner adequately treated or not? So we are seeing a lot of reinfections, especially congenital cases coming from reinfection during the pregnancy. That is why the title for our presentation today is why the clinical and epidemiological coordinated action is needed. Anytime that you see a patient on the clinical part, it's not enough to get correct diagnosis, provide treatment, it's more than this. We need you to stop the spread of the disease because we need to ensure more than clinical, the epidemiological part take care for partners and provide screening and treat it as well. And finally, this is a slide to bring a resume about what the health department are doing right now in response to a rising number for general syphilis and congenital as well. So we're doing a kind of SOR that means syphilis outbreak response. It's a design plan and we would partner with, community, facilities, providers. It has been designed on 6 main branches to stop the spread disease, and then including enhanced surveillance, disease investigation and public health follow-up, outreach services and education, community involvement and mobilization, enhanced clinical operation, you are part of this, and public information and awareness. And this is a photo for our DIS performing the field investigation. So it takes several processes. The first one is when we got a confirmed case, we then patient, make an interview. Sometimes it's very hard to reach the patient. We call more than 3, 4 times, and then we send a letter. And then if they didn't respond after the letter, they go out to the field looking for these people and getting that people, bring these people to screening and treatment. And believe me, it's very hard. They can, call you their experience, but this is a crucial part to ensure the spread disease can be controlled right now. And finally, this is the clinical operation that is part of. I just bring this because we are now getting a new novel strategy that has been go out and engage education on the providers and facilities. So we are meeting with a lot of provider, nurse practitioners, medicals, OB, pediatrician, infection disease doctors, a lot of them, because we need to everybody know in our community what is the real situation. And this strategy coming because a daily observation for our routine show many cases have been reporting just with RPI. So people doesn't ensure getting a confirmatory. Many people are using FDA as a confirmatory. And on that point, we need to redraw this patient and evaluate again to ensure it is or not is an infection. We are getting a lot of report with patients with inadequate stages. So sometimes they get 3 doses, everybody get 3 doses, doesn't matter, it's 1 month between, 15 days between. So, and inadequate stages and also treatment. We are seeing a lot of people that maybe doesn't have insurance or access to. So please, on that point, call us and we can refer them to our Houston clinic that provide a screening and treatment for free. And some people never report in cases. So finally, this is some tools that we are designing also on the health department to get information for you. I'm gonna just emphasize the syphilis just a call away. It is a hotline that we are in charge to ask, to respond any question regarding previous diagnosis, screening, previous lab treatment, and even partners, okay? For now, it's available during business hour, but we are seeing a lot. As far as today, we have around 1,500 calls for providers like you on the daily basis, especially labor and delivery rooms, to ensure if the baby need or not need treatment. And also you have the syphilis scenarios that provided too that we are sharing with you. And this is the hotline. And finally, is a question, what can you do to stop the spread of syphilis? Share your comments. Treat, educate, stage, adhere to guidelines, obvious, yes. Education, yes. Well, I don't know, you have any question for me?
Have you seen a rise in HIV in addition to syphilis?
Yes, I don't have the exactly number about this, but yeah, probably Dr. Stanley can give more advice because it's not directly mine. I just working with congenital, but yes, we are seeing a lot of cases regarding this. Dr. Stanley, regarding HIV.
Yeah, I'm not used to this level of technology in my life. I work for the Houston Health Department. Our city doesn't have that level of a budget. To answer the question regarding HIV, we are seeing an increase in new HIV cases. Some of them, a large number of the cases are people who have recently relocated to the Houston area. So we're still trying to flesh out, is it more people moving to the area or is it new novel cases? Right now, it seems like a mix of both. We do not have the numbers to say exactly what levels we're at.
And finally, we have a QR code. If you are kindly respond, your feedback is very important for us.
I have a question. Is there a direct number for the physician for consultation? As you said there, if you're unsure about results or if there is record of.
Physician, yes. not for patient, not for everybody. Yeah, that one, yes. Yes. So sometimes we are out because we are a small team. Sometimes we are out, sometimes, for example, yesterday we got a internet disconnection for any reason. But if you call, please leave a complete message, who you are, what is your request, and as soon we can, respond your question and call back.
Just to be on the same page, what would be the turnaround response? So this way we're not thinking it's too delayed.
Be less than 24 hours. Yeah. We basically take care of that every morning. We get there, we hear the voicemail, we get callbacks, and also we have other staff that are trained to do the medical record search. Do you have any other questions, or maybe you want to share your experience with syphilis, or maybe has any comments or feedbacks?
I had one more question. So just because we ran into this issue, and sometimes if the bacillin is not available, we could send them to receive medication somewhere, correct?
So we have actually 3 clinics across town. We have Sharpstown, North Side, and also Sunnyside. They're located actually on certain specific points on North area, South, and West. And then if you have any patients that you feel that it might benefit going from the clinic, like getting treatment, we can for sure receive them and provide that treatment for them, and not only them, also their partners.
Information on the clinic is on your provider.
Yes, in the provider toolkit, we have more information about the clinics. And also, I would like to take a time to give you thank you because for receiving us today. But also, I would like to get one of our DISD, if you could please come here and talk about your experience, because sometimes I feel the job that they do, it's so important and it goes so unnoticed, but they are key to stop the spread of the disease. They're actually the heroes of this game. They're the ones like taking everybody. I'm gonna share with you this.
How y'all doing? So we, as a disease intervention specialist, once the information does come into our office, we do reach out to the patients, and try to get as much information that is not given to providers, demographics, if they've had any symptoms before they went to the doctor, a little bit about their medical history, their social life, mostly about their partners, so that we can get the partners in to get treated, tested and treated as well. The hardest part is actually trying to get that information from them, because they say, oh, we've already talked to our provider about that. So, and then most of them don't know that we're gonna call, because they don't know that this information is provided to the city of Houston, to the health department, because they think it's confidential just to their provider. So that's one of the hardest things, going out into the field to try to actually locate these people, to try to get all of this information. So. And we do go out. We go out knocking at people's doors, family members, emergency contacts. We actually have to get out and do the footwork to actually locate these people. Any questions?
Have y'all used social media to try and reach any of these people? Like you're knocking on doors, but with the digital age and everything, just wondering if that's an avenue.
Yes, we do have a website.
We do use social media, especially if we know that a patient is on social media. We do have a team that actually reaches out to them on social media to let them know that, hey, we need to get you to contact us back, but a lot of them think that it may be scammed. So we run into that issue with reaching them as well.
And remember, part of our job is keeping on confidentiality of the, cases and partners as well. And the point about if the patient disclose a partner at DIS, contacting them, say something like, hey, we know maybe you have been exposed. We never, disclose people names, times, location, maybe the people can assume somebody else saying something because we need to keep in the confidentiality as well.
And that's, she has a question.
I was just gonna say, what is your process when you're not able to locate someone?
The information that we do receive from providers, we start there. And then once we can't locate them, we try to do all avenues of record searching to try and locate the patient as well, try to find emergency contacts. So, we look, if we can't find them, you know, we try to reach back out to the providers and say, hey, can you let this patient know that we're trying to locate them? When was the last time that you have reached out to this patient? That's what we try to do.
And also we complete that complete medical record search on any single database that we have available. And checking for data we can find on Acrim for relative or, you know, people who are maybe related and try to get in there. So when they say field, it means it doesn't just to the patient, it's every people around and maybe we got information are being around this patient. So it's a hard work.
And if I may brag on our DIS people for a moment, I got to ride along with some, and a lot of institutional knowledge is also used. A lot of wisdom, savvy, and knowing the community, having relationships with all sorts of different institutions, all different sorts of people. During one ride, we pulled over by a gas station, looked behind a dumpster, found a guy that told us where this other person would be and that this other person was going to be in a hospital. And within 5 minutes, we found that human being. So they're a little too humble for my taste. They really use a lot of their resources and institutional knowledge.
Thank you all for your attention. It's just after 1 o'clock, so we'll go ahead and conclude. Thank you.